Hi, my name is Sarah Canham. This presentation is entitled Homeism, Naming Discrimination Against Persons Experiencing Homelessness. We acknowledge with gratitude that the research for this presentation was conducted on the unceded territories of the Coast Salish people, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations, on which we are privileged to live, work, and play. We would also like to acknowledge the funders and our community partners who contributed to this research. Though stigma has been variously defined based on a broad array of circumstances and theoretical approaches, Irving Goffman, who initiated conceptualizations of stigma, defined stigma as an attribute that is deeply discrediting, which reduces someone from a whole and usual person to a tainted, discounted one. Stigma has been recognized as relationship and context-specific process, which involves the labeling of human differences, negative stereotyping, separating the us from them, and unequal access to power. Stigma has been found to lead to status loss, discrimination, social exclusion, and other unequal outcomes. There is a long-standing recognition of inequities that individuals of certain demographic groups experience based on their race, gender, and age. At their core, racism, sexism, and ageism are based on assessments of someone as an other, based on the color of their skin, their gender expression, or whether someone appears as old or young. In this study, we examined stigma amongst persons experiencing homelessness, which we conceptualize as distinct from other forms of stigma. And so, we have defined homeism as the stigma and discrimination against an individual based on their housing status. Examples of homeism can most clearly be seen amongst persons living on the street without any shelter. However, we feel this term can be applied to anyone who experiences stigma or discrimination based on their housing status. When we look at the literature on stigma among persons experiencing homelessness, we can organize the literature into an ecological framework whereby, at the intrapersonal level, people experiencing homelessness have been found to engage in self-stigma. At the interpersonal level, the general public, neighbors, family, and friends discriminate against people experiencing homelessness. And at the structural level, there are discriminatory policies in place that stigmatize behaviors of people who are experiencing homelessness. The literature also describes outcomes of stigma, including social exclusion, violence, criminalization, dehumanization, poor physical and mental health, as well as internalized shame and depression among people experiencing homelessness, frustration, anger, aggression, having lowered self-esteem, mistrusting healthcare or avoiding healthcare, or leaving healthcare against medical advice. To build upon this existing literature, we conducted a secondary data analysis that examined the hospital discharge experience for people experiencing homelessness, and we asked this following question of the data. What is the experience of stigma among persons experiencing homelessness during the process of hospital discharge? This was a community-based participatory research project based in Metro Vancouver, British Columbia, between November 2017 and January 2018. Semi-structured interviews were conducted with 20 persons with lived experience of homelessness, 10 healthcare providers who were based in hospital settings, and 10 shelter or housing providers who worked in community or were liaisons with those working in healthcare settings. We conducted a thematic analysis. And so based on our analysis, we are proposing to build upon this socio-ecological model of the contributors to the experience of and the outcomes of stigma experienced by those who are experiencing homelessness. As we saw in the existing literature, we also found in our data that stigma occurs across these ecological levels. For instance, in our study, it was reported that when people experiencing homelessness regularly access the hospital and become known to hospital staff, they are stigmatized and treated as less worthy of care when compared to patients who are less frequent users of the hospital. Landlords, too, were implicated as perpetrating discrimination against those who are experiencing homelessness. And our data showed that people experiencing homelessness stigmatize themselves through internalized stigma. As one shelter or housing provider stated, honestly, there's a real problem with discrimination at the hospitals. They will release somebody to the street if they have any history of being in a shelter system or if they have an appearance of some sort, and they will keep other people for months. It's basically classism, and I'm not kidding about this. Our data also pointed to a number of reasons why people experiencing homelessness are stigmatized, what we think of as the precursors to these experiences of stigma. And this could include perceptions about alcohol and other drug use, expectations for how people behave, as well as healthcare provider burnout. And so here a healthcare provider participant stated, staff often treat patients not great, especially patients that are homeless or are struggling with addiction issues or might be working in the sex trade. There can be judgments that come across that are really clear. Or staff are burned out and they just aren't working from a very patient-centered focus, and then patients get angry and frustrated and they leave. So in addition to the experiences of homelessness and the precursors to this stigma, our data highlighted a number of negative outcomes of the experience of stigma, including disengaging from healthcare altogether or not wanting to engage with healthcare providers. As a shelter or housing provider stated, some leave against medical advice because they're feeling treated poorly or looked down on or talked down to or judged, or assumptions are made as to why they're there. They're not taken seriously. They don't have a voice of knowing how to advocate for themselves and tell them what they're thinking or feeling. And then they give up, and that's why the infections get worse. Related to this, our findings indicate that people experiencing homelessness also have experienced treatment disparities, including not being listened to, not being communicated with, different treatments overall, having rushed care, or being discharged earlier than other patients. This can contribute to people's disengagement from the healthcare system as well. As one person with lived experience stated, if I was a 55-year-old woman, I don't think I would have quite got the same treatment, and I don't think that just because of some of my demographic issues and some of my lifestyle problems that I should be treated any different than another member of society. The 55-year-old woman and the 31-year-old drug addict should get the same treatment. It just makes you feel like less of a person. A third category of outcome described by participants was the institutional trauma the people experiencing homelessness experience as a result of both trauma itself and the differential treatment that are experienced in the healthcare system. And this further contributes to the disengagement of people experiencing homelessness from the healthcare system. As this healthcare provider states, often there's institutional trauma. Somebody was in a residential school, or somebody had a negative experience in a psychiatric ward, and then we're just going to put them back in a medical ward and it feels the same. There's a myriad of reasons why people don't want to come in or don't want to be in a hospital. And so finally, taken as a whole, these outcomes of stigma, institutional trauma, disengagement from healthcare, and treatment disparities result in poor health for those who are experiencing homelessness. Throughout our discussions on the needs of people experiencing homelessness during the hospital discharge experience, there were a number of potential solutions that were suggested as a way to combat or reduce stigma. At the individual level, solutions to address stigma and discrimination included first, viewing people who are homeless as persons who are in need of respect and compassion, and second, translating that view into meeting people where they are at. At the interpersonal level, it was suggested that advocating on behalf of people experiencing homelessness was one method of ensuring that stigma and discrimination do not prevent people experiencing homelessness from getting the care they need when they are unable to advocate for themselves or they are hesitant to engage with healthcare in the first place. At the organizational level, several ideas emerged regarding how to influence the ways in which people experiencing homelessness are treated. First, participants suggested that by finding ways to reduce provider burnout, that treatment of people experiencing homelessness could be improved. Participants also suggested that healthcare professionals receive education and training on how to engage with complex patients and implement trauma-informed and recovery-oriented harm reduction approaches to meet these patients' needs. And at the broadest level, participants suggested that there is a need for communities to change how housing and homelessness are perceived both within healthcare and more widely. So where do we go from here? By naming Homeism, we aim to instigate housing activism which recognizes housing as a human right and counteracts the neoliberal not in my backyard mentality. As well, by naming the discrimination against persons experiencing homelessness, we hope to promote future scholarship on this phenomenon that can be pursued alongside interventions that are aimed at eliminating Homeism. Thank you for your time. I look forward to any questions you might have. Please feel free to reach me at any time by email or connect with me on Twitter or see some of my other research on my ResearchGate page.